and reviewed pathophysiology of cancers, including the difference between benign and metastatic or malignant tumors, okay? Now, if you printed the PowerPoints off before this morning, I added to them this morning. You guys know I can't leave anything alone. All right, so one of the first things that we do as nurses is we work with patients and communities for cancer prevention. That's one of our things. We would rather people just not get cancer. So, I mean, we would rather people not get chronic diseases. So that's a lot of what we're supposed to do is educate people. Even if they come in with an illness, then we should be going back and teaching them about prevention for other diseases. I mean, if somebody comes in with a broken leg and they smoke, we should talk to them about smoking cessation. I know it's a pain, but we're supposed to do that with everybody. And you never know when somebody's going to be susceptible to it. I had a guy who came in with cellulitis in his leg, and he was a smoker, and I convinced him that the reason that he got cellulitis and it wouldn't heal was because he smoked. And there's a good chance that it was. I mean, that is something that can add to that problem. So I convinced him, and he was all about stopping smoking. He asked for the patch and Wellbutrin and all that. Who knows if he followed through? But you never know when you're gonna actually get somebody to listen to you. Now, if they're 89 and they're smoking, they're not going to stop. Okay. So what you should be able to do at the end of this part of the unit is talk about health education and preventive care and how it can decrease cancer. Talk about cancer markers and genetic testing, components of the nursing assessment of the patient with cancer, and provide patient teaching for people undergoing diagnostic evaluation. Now, people who undergo diagnostic evaluation, that's something that you've already done. You talked about that in 330. So all you have to do is apply the knowledge that you got from 330 to the specific testing and circumstances of the patient now. This isn't something that Ms. Eskew and I are going to teach every unit. We might teach you some different things, but we're not going to teach it every unit. All right. So the nursing role in cancer, don't you guys love the guy from Khan Academy? The psychotic cells? Because that's what they are. Cancer cells are out of control. They do not conform to societal norms. And societal norms in cells is you don't invade other areas, you stick together, and you die when you're supposed to, and you don't reproduce unless you're needed. Those are the norms in the cellular world. Okay? But what cancer cells do is they just ignore all that. They proliferate like bunnies. Faster than bunnies, because that's what they do. They're programmed to do that. That's all they do. And suck all of your resources out. Okay? They also don't die. They don't have that cell suicide gene in them. They don't stick together, and they invade. Those are characteristics of cancer cells. The other thing that they do is angiogenesis. And what's angiogenesis? They create their own blood supply. Now, the problem with the blood supply that they create, the vessels, what's one of the problems with the vessels that they create? What happens if you decide to build a road and the contractor comes up to you and says, well, you know, it's going to take 2 months to build this road because you got to get a good foundation, you got to pound all the dirt down, and then you got to put gravel, and then you got to put sand, and then you have to put tar, and then you can put the pavement over that. But you don't do that. What's wrong with that road? It's fragile and weak. It's going to break down. You're going to get potholes in it, right? Same thing with these new vessels. They're weak and friable. They will tear up easy. So there's this risk of bleeding from these new blood vessels. And then the other thing that happens is they invade other tissue and they can erode into other tissue. So that's a couple of the problems with this new angiogenesis. Now, if you look at the pictures up here, those things that look like jelly beans, I'm not sure why they're jelly beans, but don't they look like jelly beans? That's the way that we can fight off cancer. Nutrition, exercise, rest, and it says meditation. Stress reduction, okay? I don't know about meditation. There's other ways to reduce your stress, but definitely stress management. And then once you get over it, or once you develop it, treatments include surgery, chemotherapy, radiation, and targeted therapy with immune targeted therapy and some hormone targeted therapy. Now, primary prevention, education, and counseling geared toward reducing and managing controllable risks. We're addressing the risk factors and the ones that we can change, like diet and exercise, weight management. At the risk of getting cancer, if somebody's overweight, increases geometrically with each BMI category you go up. So people who are in the very obese, with a BMI of greater than 45, they're at incredible risk for cancer. But even just having a BMI of greater than 25 increases your risk. And not only does it increase your risk for getting cancer, it increases your risk of having really bad outcomes. Okay, so that's another reason for weight management. So on the right side, there's things that they can do on their own. And on the left side, there's a couple of things. Immunizations. What kind of cancer do we definitely immunize against now? Well, HPV is what we immunize against, but it's for cervical cancer, right? And should we just be immunizing women? No, because men are actually asymptomatic with venereal warts, or HPV, however you want to say it, 99% of the time. And they pass them easy. Prophylactic surgery, removal of the organ or the tissue that might become cancerous. That's what Angelina Jolie did. Avoidance of carcinogens, smoking, environmental and occupational exposures. That means wearing appropriate protective gear. And drinking in moderation and not using other drugs, social drugs. We're having the underneath of our house treated, getting like a new vapor barrier and having it sprayed to prevent mold and stuff like that. And that spray is actually a carcinogen. But the guys who've been under there haven't been wearing their protective gear. And they probably do this, 3 or 4 times a month. And it's in an enclosed area, and they're spraying up. I mean, like, how much exposure are they getting? But they never, I asked them about that. They came out blue. They came out from underneath our house blue. They look like Smurfs. And I said to them, I said, aren't you supposed to wear some protective gear? Yeah, but it's a pain. It makes us hot. Okay. All right, secondary prevention is early detection. Early detection of disease. This isn't preventing disease. Screening and secondary prevention does not prevent disease. Early detection helps you treat it early, and the earlier you treat some diseases, the better the outcome. So we have screenings where people can come in and they can do self-screenings like breast exams, self-breast exams, or men should be doing testicular exams. Skin assessment, everybody should be doing a head-to-toe skin assessment to screen for skin cancers. What are some other kind of assessments you can do at home? Oral. Definitely oral. Checking out for oral cancers, especially if you drink heavily or use any kind of tobacco products. Okay. Regular health care, going into the doctor and having blood tests done and regular screenings done. Those are another important thing to do. The American Cancer Society has recommendations for cancer screenings for prostate cancer and breast cancer. They start off with a digital rectal exam, and then for prostate cancer, and then breast exams for breast cancer. Also for prostate, they'll do a PSA, and for breast exams, you'll get a mammogram. Cervical cancer screening, they'll do Pap smears. Colon cancer, they'll start out fairly non-invasive where you get those occult blood cards, right, where you're checking for blood in the stool. What you do is they're a card. Has anybody seen those? They're a little card, and patients take them home with them. They have to do 3 sets, a couple days apart, not the same stool sample, not from the same stool pile. And they smear the stool on the card, and then they send it to the doctor's office, and the doctor puts some developer on it, or they'll put some developer on it, and if it's got blood in it, it'll turn blue. And they'll do that with 3 different cards over a couple of weeks. The problem with that is you can get a lot of false positives with it. What's one reason why somebody would have a false positive on occult blood in the stool? Menstruating, yeah. Hemorrhoids. That would actually probably show up as a positive for blood, but it's not necessarily a false positive. Iron. If anybody's taking iron, if anybody's taking Pepto-Bismol, that'll show up as a false positive. And then for colon cancer, flexible sigmoidoscopy. Karen. Flexible sigmoidoscopy or colonoscopy, right? That's for colon cancer. And then they also are recommending screening for lung cancer with a low radiation CT scan. If somebody's at high risk for lung cancer, they have a family history of it, or they're smokers, right? Let me talk a little bit about. When you start talking to patients or people about doing screening tests, you'll get a lot of. Sometimes you'll get a lot of pushback from people because they don't want to have the screening done. I mean, I'm 52. I think I've had 2 mammograms. I should have had like 10. And I don't go in for them because I don't have any risk factors for it. I have 0 risk factors for breast cancer besides the fact that I'm a female. But my first mammogram, I had a false positive. And they took me in, they did an ultrasound. Well, they still thought something was wrong after the ultrasound. So, of course, I don't get the ultrasound appointment for 2 weeks. So I'm a basket case for 2 weeks. And then the ultrasound still shows something, so then they want to do a needle biopsy. And I can't get that done for another 2 weeks. So I have 4 weeks of just freaking right the heck out for somebody who has a low risk profile for breast cancer. So I go in like every 3 years now and get one I'm due this year. I do every 3 years because I have a low risk factors for it. And that's one of the problems I think we don't look at when people recommend that we have these cancer screenings. The anxiety that comes along with false positives, because they do have false positives. And then the pain and discomfort of having to get the follow-up stuff. You know, we need to think about that when we willy-nilly recommend people get screenings for stuff, and I don't think we do. A lot of the screenings have changed recently to decrease the how frequently we get it. How come? Insurance. One thing that those people up there at Washington, D.C. did not think about, that they have all these recommended tests and doctors are required to do them. And so they're telling their patients this, and whether they need it or not. And it's really depleted the supply, the financial supply and stuff for that kind of stuff. I mean, they're doing it on people who don't need it. All right, so when you're talking to your patient about monitoring for cancer, you can tell them some things that they need to look at. And early disease detection uses this caution mnemonic: change in bowel and bladder habits, a sore throat that doesn't heal, unusual bleeding or discharge, thickening or lump in the breast somewhere. And thickening means either in the tissue or the skin. Okay, changes in the texture of the skin or a lump. Indigestion or difficulty swallowing, obvious change in moles or warts, and nagging cough or hoarseness. Other nonspecific signs of cancer: fatigue, weight loss, and unexplained pain. And it's usually a kind of a chronic pain, not kind of this episodic pain. Examples of cancer markers. These are things that we talk about. Cancer markers are also known as tumor markers. Okay, and these are blood tests or you can test urine or cerebrospinal fluid. You can actually test a lot of different kinds of fluids and tissue for cancer markers, and an elevation can suggest a tumor or a malignancy. One of the ones they used to do really frequently was one that's a general marker for inflammation. They quit actually using that one for cancer because so many people are positive for so many reasons. I mean, like, you know, if you ran a mile the day before you go and get that test, you can have a positive result. So they don't do the one just for inflammation anymore. But if you have the cancer markers, should be done in conjunction with other testing in consideration of the patient's history, past medical history, and family history. It shouldn't be done in a vacuum and say, oh, you know, you had this cancer marker test done and you're positive. Okay? Other reasons they do it is to determine the extent of disease, to stage the disease, and determine treatment. And you can also use cancer markers to determine effectiveness of treatment. One of the ones we talk about most frequently is a PSA. That's a cancer marker. But a PSA can be elevated because somebody had a lot of sex. Okay? It can be elevated because there's a slight inflammation of the prostate, which is normal. It can be elevated because somebody has a UTI. Okay, so it's a fairly, you know, they're not all, if they come up positive, it doesn't mean that they have cancer. Okay? But alpha-fetoprotein is one, and that can determine liver and germ cell tumors. What's a germ cell tumor? What's a germ cell? Well, it has to do with sperm and egg production. Germ cells, actually, those are the ones who produce sperm and eggs. So it's ovaries and testes. So alpha-fetoprotein is a test for liver and germ cell tumors, and they test the blood. It can help diagnose liver cancer in response to treatment. For germ cell tumors, so for testicular or breast or ovarian cancer, it can help stage the disease and also give, that should say, prognosis. I thought it said progress. Prognosis. What's the patient's prognosis? And then also it can help with determining how well treatment is working. I mean, if somebody's getting treated for ovarian cancer and their AFP is still going up, then the treatment's not working. Okay? And then there's this B2M. That's a test that will actually give you information about leukemia, lymphomas, and multiple myeloma. And they can look at the blood, urine, or the spinal fluid here. What is a genetic marker that we talked about in relationship to leukemias? A specific kind of chromosome. It's a city. Philadelphia. That is a confirmatory test for leukemia. That's a confirmatory test for leukemia. Other diagnostics, physical exam, endoscopy, either colonoscopy, endoscopy. You can also have, they can look at your lungs, right? They can also do a cystoscopy. We had a patient who was getting a cystoscopy the other day. Whose patient was that? April. She's in the other class. A cystoscopy, the woman had metastatic cervical cancer, and she was having bleeding in her bladder. So they were doing a cystoscopy to see what was going on up there. Okay? So you can look a lot of different places endoscopically, and that helps you visualize stuff. The other thing they can do with endoscopies is they can pull a biopsy, and I think I have some pictures of that later on where they're pulling biopsies. X-rays. I mean, X-rays, you saw what it looked like when we looked at multiple myeloma. You can also see you can see tumors because tumors tend to be more dense than regular tissue. Okay? PET scans. What do PET scans tell you? PET scans are they get hot spots. Remember, I think when we were in pathophysiology, I talked about PET scans when we were talking about bone disease and how they had hot spots. And the hot spots show increased metabolic activity. So if somebody has cancer and they get a PET scan, then the PET scan, that's going to show hypermetabolism in a specific area, and that can indicate where cancer is. That's a real good test for people who have diffuse cancers like lymphomas or leukemia. It can also show where metastases are. Serum tests, all kinds of blood tests, and that includes stuff like CBCs and chem panels, because you just don't want to know if somebody has cancer, you want to know what the effect is. Bone marrow aspiration and also bone scans. All right, nursing management of the patient with cancer. Again, objectives, I want you to be able to talk about the differences related to surgical procedures, the roles of surgery, radiation, chemo, biotherapy, and other therapies, management of a patient with cancer, and nursing process, using the nursing process to develop a plan and education. Do I expect you to be able to tell me the difference in medical management of breast cancer and ovarian cancer, or ovarian cancer and lymphoma, or prostate cancer and colon cancer? No. I'm expecting you're supposed to graduate a generalist, not an oncology nurse. So what I expect you to know is the general management of somebody who has cancer, and cancer as a disease process and what it does commonly to people, and what the treatment does to people, okay? The patient's response to it, not specific treatment modalities with chemotherapy, not the specific combination of chemo for breast cancer that's not a BRCA2. I don't expect you to know that. I don't expect you to know that this specific chemotherapy that's an anti-metabolite is the only one that causes heart failure. I don't expect you to know that. I expect you to know that chemotherapeutic agents cause really crappy stuff to occur in your body, and what you can do as a nurse to help that patient. Okay? So these are common concepts associated with cancer, things that you're going to be helping the patient deal with. One is coping, and it goes cancers, okay? Cancers. Coping, altered oxygenation, and anemia. People who have cancer have nutrition problems. They have concerns with infection and bleeding. You need to evaluate pain and elimination problems. Review fluid and electrolyte balance, and then look at skin and tissue integrity and support health promotion. One of the things I think that patients even forget about is, yeah, you know what, I have colon cancer. I still need to get screened for prostate cancer or breast cancer or the other kind of cancers. I still need to get screened for other diseases. I still need to pay attention to heart disease, preventing heart disease. I still need to pay attention to not getting the flu and all that kind of stuff that, they may think, I got the big C. I don't have to worry about anything else except for that. That's not true. They need to look at other stuff. They need to maintain their health. All right, so for coping, you're going to help the patient cope with the diagnosis of cancer, especially older people. Older people think it's the big C. In their lifetime, cancer has become more curable and people live longer with cancer, but they still think that it's a deadly disease. In a lot of cases it is. So when they hear the word cancer, they think they're dying imminently.
And a lot of them don't even want to treat it, though.
No, they don't want to treat it because what they hear is treatment is worse than the disease a lot of times. All right, so also you have to help them cope with the effects of cancer, those common problems that people with cancer have. What are some of the common problems people have with cancer? What? What'd you say?
Nausea, vomiting.
Nausea and vomiting. Alopecia. Anorexia. Did you say something?
I said hair loss.
Hair loss. What else?
Increased infection.
Increased risk for infection. Pain. Bleeding. Huh? Fatigue. reduced appetite,
Anxiety.
anxiety. All these things that come along with the diagnosis of cancer. Cancer can affect different organs in the body, but the systemic effect of cancer is similar no matter what kind of cancer you have, because remember, cancers are a high metabolic demand disease, and they frequently shoot off toxins and stuff that make people feel bad. And then they have this fear of dying. All right, so altered oxygenation and anemia. You need to talk to them about fatigue and activity intolerance. And what are some of the things that you tell people who have fatigue or activity intolerance? Rest, take a nap, plan a nap time. What else?
Nutrition. Good nutrition.
Good nutrition. Prioritize your activities and then pace them. And then energy conservation practices, like getting a shower chair and sitting in the shower instead of standing up. Pushing instead of pulling. One of the things I've got, my mom doesn't have cancer, but she's got a big problem with fatigue. And one of the things I finally convinced her of is when she was living at the apartments at Laurel Crest, she lived on the very far end of the building from the dining hall. And she liked going down there, especially after my dad died, for socialization and stuff. But she would want to use her cane and walk all the way down there. It was probably, 100, 200 yards at least. And which is that's a long distance for some old people. And that was to get to the elevator, and another 100 yards or so to get to the dining facility. I finally convinced her, use the scooter. We got her a hover around. So now, and she didn't realize it, but it's actually one of those things that makes her look really, it's like having a Cadillac. She's got a scooter. And she goes down there, and the thing is with that is, she's not exhausted herself getting down to the dining facility, so now she has the energy to eat. So, it's not just that saving energy so you can do stuff later, it's saving energy so you can eat. You need to be able to do that, too. All right, and then tissue perfusion. Tissue perfusion problems cause all kinds of stuff, especially where your skin's concerned, right? So you need to think about the fact that if they have altered oxygenation and anemia, they're going to have to look at skin and wound healing and stuff like that, okay? Nutrition. Nutrition is a big thing because there are so many aspects of cancer and cancer treatment that affect nutrition. Whether you don't want to eat, or whether you can't eat, or nausea or vomiting, or you need certain nutrients. Okay? So monitoring nutritional status, and a lot of times it goes with, getting the patient to write down what they eat. They need to do a food diary. Small, frequent meals are easier to take in and digest than large meals where they sit down and eat, try to eat a big meal. Nutrient-dense foods, not Cheetos. Cheetos aren't going to do anything for them. But nutrient-dense foods with quality calories and proteins. Vitamin supplements, and supplements like Ensure or Boost or something like that. And it's hard sometimes. Those things don't taste all that great. They really don't. I mean, we tried so many different things for my mom and my dad both to increase their nutritional status. And the best way we found to do it was to get a flavorless protein powder and to mix it up in a milkshake for her. If she can't taste it, she'll do it. You put anything in there, it changes the taste. Like, we tried Ensure, we tried Boost, we tried Slim Fast powders, we tried the Carnation Instant Breakfast. She could taste it, she wasn't going to take it in. So you got to find stuff that they like. Treating the anorexia. What are some ways to treat anorexia? My active learning. Oh, is that mine? I thought I picked up your cup for a minute. What? Scheduling meal times and getting them ready, making meal times a pleasant experience. Let them have a spliff before they sit down to eat. Not in South Carolina. Apparently, though, you can actually, because my mother tried this. Tried to get, you can get a special dispensation for marijuana for medical purposes in South Carolina. So my mom was in the process of doing that before she got sick this last time. Marijuana increases your appetite. Puts a big munch on your head. Okay? Steroids. I mean, they use steroids to treat cancer, but steroids make you hungry. How many of y'all have been on steroids? You talk about being some hangry people. Steroids, a glass of wine can be something that increases the appetite. Okay? If the patient's condition allows it. Giving them food that they like. If they have problems with their mouth pain, then give them stuff that they can eat. And what that means, we'll talk about that when we get to stomatitis care. Also, what's another thing? Oh, Zofran or other antiemetics. They have antiemetics that are specifically for patients who have cancer, but Zofran every 6 hours. They get these sublingual ones, or you can even get a cream. It can be compounded into a cream, so if somebody's having really bad nausea and vomiting, there's several ways to get this into them. But giving it to them scheduled instead of right beforehand. Okay? And then helping to deal with stomatitis and xerostomia. What's the difference between stomatitis and xerostomia? Xerostomia is a dry mouth, and stomatitis is when you have lots of sores and stuff. And the thing is a lot of, remember, when we talk about cancer, it affects, I'm trying to think of how I talked about this before. When we talked about anemia, remember when we talked about anemia and we talked about why people who have mouth sores with anemia? It's because they don't have the oxygen to turn over their cells. Well, the same thing can happen with cancer, to where they have GI problems from the mouth all the way down. Okay? And they can have this problem with desquamination, where they lose all their skin and stuff like that, and it's sore and raw feeling. So you don't want them to eat nuts or seeds or celery or raw carrots. You know, stuff that's gonna hurt swallowing. Small spoonfuls, small meals, soft foods, gravies, soups, stuff like that that's easy to swallow. Some people say that they can't swallow pills because their throats hurt or because their mouths hurt, so crushing the pills and putting them in applesauce or pudding or ice cream, something like that, will help with that. Keeping up fluid intake is really important. Lozenges, Sucrets. I know Sucrets kind of went out of fashion, but they're really good for numbing your mouth and your throat. And the way that we monitor it is is all these lab tests and also weights. Concern with infection and bleeding. Which labs would you want to monitor if you were concerned about your patient's risk for infection and bleeding? White blood cell count with a diff, right? What else? Platelets? PT, PTT? Bleeding times? All that kind of stuff, right? And then it's the same thing that you do for patients who are at risk for bleeding, any patient who's at risk for bleeding. You know, you have those interventions, nursing. Where's the nursing intervention for patients who are at risk for bleeding? What? Reduced needle sticks. What'd you say? Impaired tissue perfusion. If they're bleeding, they may not be getting blood to that area. What else? We're talking about the risk for bleeding issues here. So what specific to bleeding? Electric razors, limit sticks, soft bristle toothbrushes, right? Helping prevent falls and injury. And then the stuff for infection. You guys know what to do to help prevent infection, right? You know that. It's not something you need to relearn for this class. All right, evaluate for pain. Oh my God, you know how to do that, don't you? Do you know how to evaluate for pain? Do you know how to treat pain? Yes. Meds. Yes. I'm sorry, if I have cancer and you want me to use guided imagery. Elimination. Chemotherapy and radiation can either cause constipation or diarrhea, and you need to treat whichever way it goes, okay? You need to give the antidiarrheals, anti-motility drugs, or you need to give fiber. Okay? And then review fluid and electrolyte balances. There's lots of causes of imbalances. The nausea, vomiting, diarrhea. You know, if you're nauseous, you don't want to drink anything, right? Blood loss, because we do have problems with blood loss. And then GI irritation can contribute to fluid and electrolyte balance issues. And then skin and integrity issues. This is a big one because we have the problems with hypoxia. We have the problems with protein malnutrition, problems with the anemia, decreased movement and activity, right? They can have radiation burns. They can have irritation from chemotherapy administration. And then we go back to that whole idea of impaired tissue perfusion. And then I already talked about how we need to help make sure that these people are still getting all their screenings done and looking at other health problems besides just the cancer and the side effects and consequences associated with it. All right, so surgical interventions for surgery. Y'all did pre, peri, and post-operative care last semester, right? Didn't you? Yes. So you're going to apply that now. This is not new stuff. This is stuff that you did last semester. So, oh my God, we have to learn about care for the surgical patient, and the chemotherapy patient, and the radiation patient. No, you already know about this. And you know, there's standard stuff that you do for perioperative patients. There's standard stuff that you do. And you just apply that. So you review those chapters in Pelico, review those chapters in ATI, and you've got it. Intraoperative stuff, most of the stuff that you're concerned about in intraoperative has to do with stability, patient stability, risk for infection, and stasis injuries. What do I mean by stasis injuries? DVTs, pressure ulcers, hypoventilation if they're on a vent, right? You know, how do you help prevent problems related to hypoventilation? What? I didn't hear you. Continuous use of monitoring, but what do you as a nurse do afterwards? Before and after? Yeah, you check, that's monitoring. What do you do to prevent it or to treat it? What did we do in clinical on Wednesday? What did we have to teach about? I had 2 people who had to teach, but they're both in the active learning class. Incentive spirometry. Yeah? Early ambulation. Get that Foley catheter out. All that kind of stuff that you do normally for perioperative patients or surgical patients. Got to do. Identifying, making sure that that site is marked. Right? Making sure that that site is marked. Informed consent. Blood, they have type and a cross. They don't have any jewelry on. They've not eaten. All that kind of stuff. That's your responsibility. And then pre-surgical patient education to prevent post-surgical complications. And here's some stuff about post-operative care and the different phases of it. But it starts out with stabilization. We're going to table them. Stabilizing the patient, making sure that the patient's stable, awake, and with adequate pain control. You don't want to discharge a patient who's still somnolent and doesn't have their pain under control. And does that sound goofy? Well, yeah, it sounds goofy, but we do that with people. People have same-day surgery now for cancer. You know, they come in, have the surgery, go home. Prepare the patient for discharge, and then discharge them home. A lot of patient education with that. All right, biopsies is one of the first types of surgical procedures. Nursing care depends on the location of the biopsy, how invasive the biopsy was, and patient characteristics. A 90-year-old patient who comes in for a needle aspiration biopsy of the liver is not going to respond the same way as a 22-year-old who comes in for a shave biopsy of the skin. All right, so an endoscopic biopsy, there's a couple ways they can do that. They can go in and actually clip a piece of tissue and pull it out, okay, with what they call biopsy forceps. They just go in, they snatch a piece of tissue, and they bring it out. They can also do a brush biopsy or a scraping. Now, a pap smear is a type of a brush and scraping biopsy. They put a brush up there and they twirl it around, they get cells. They can also do that endoscopically. This one over here on the left side, that's a lung where they went in and they did a brush to get some cells off it. You don't have to have a lot of cells to do a biopsy. Okay, so they'll go in and they'll brush it. They can also do a wash where they go in and they instill fluid and they suck it back out. That's another way to do a biopsy. Image-guided biopsy, this is a prostate biopsy, okay? And this gun right here, well, I'm going up there to do it. This is called a biopsy gun, okay? And it will actually shoot a needle into the prostate, and this is an ultrasound that goes in the rectum so they can visualize the area that they want to pull the biopsy from. Okay? Ultrasound guided biopsy of the prostate. Core needle of the breast, where they'll put a needle in, and it is the diameter on the inside is rather large. It's usually larger than a 16 gauge needle, and they'll put that in there, and it'll rotate, and then they'll pull it out. They'll rotate it to cut the tissue at the bottom and then pull out the tissue, and that's called a core sample. And they're usually going into an area that's identified by ultrasound again. They actually can do a thing called a stereotactic biopsy, and this is a type of biopsy I had, and if I thought childbirth was somewhat embarrassing. They lay you on a table, chest down, and then smash your breast between a mammogram thing, and then guide a needle into it while they're looking. Yeah, stereotactic biopsy. Shave biopsy for the skin, that's where they just take the top layer of the mole off, or the lesion off, and they look at it that way. A shave biopsy doesn't leave a scar. A punch biopsy was where they go in and they pull a core out. They did a shave biopsy on my arm here for a potential skin cancer. They didn't get enough cells, so then I went in for a punch biopsy, which they'll have to suture, and they use Vicryl suture material on me after I told them not to because I'm allergic to it. So now I have a big scar on my arm. See, so biopsies, these kind of biopsies aren't without potential complications. So a punch biopsy goes a little bit further. This is an excisional biopsy. This is a perioral of the breast. Excisional biopsy where they're going in, they're trying to get tissue from underneath the nipple area. All right, and then you can also have a curative or a primary surgery. I wanted to show the different kinds of mastectomies in particular because we see those a lot in the hospital, either new or old mastectomies, and there's several different ways that they can do it depending on how much tissue or how much of the margin they want to get out. They can start off with a lumpectomy where they only take the lump out, the actual cancerous tumor out, and a wide margin of healthy tissue around it. They can do a partial mastectomy where they take a wedge-shaped form out, a wedge-shaped piece of tissue out. They can do a simple mastectomy where they're only taking the actual breast tissue out. They don't take any lymph nodes out. Then you can have the modified radical where they take the lymph nodes out into the arm. This is when you start having problems with lymphedema. And then a radical mastectomy is where they actually take out the chest wall muscle there, and it comes out concave when it heals. Okay, this is just like any other surgery. You're going to have it. They're going to have incisions. They're going to have drains. They're going to have pain, risk for infection. But along with this, a lot of women feel like they lose their femininity if they lose a breast. So there's a whole nother level of coping for that kind of thing. There's a profile, yeah.
Isn't it contraindicated if a person has a mastectomy on that side, so not do blood pressure for stuff?
If they've had anything from a radical up, okay? If they've had a lumpectomy or a partial mastectomy, you don't have a limb alert. It's if they've taken lymph nodes out. If they take lymph nodes out, there's a limb alert, okay? Prophylactic surgery, what's her last name? Angelina Jolie. She had a double mastectomy because her mom died of breast cancer. She had an aunt who died of breast cancer, or two aunts who died of breast cancer, and she was positive for the BRCA gene. So she had a double mastectomy. That's a prophylactic surgery. And then palliative surgery is where they try to improve or maintain quality of life or improve comfort levels. It's not a cure. A lot of the surgery, like mastectomy, that's a curative surgery where they completely remove the tumor and any cancerous stuff around it, okay? But palliative surgery is where they're trying to improve the quality of life. I had a patient who would come in when I worked in Tennessee. We had a patient who would come in every couple of years or so to have a brain tumor debulked that was up here in his head. Now, he would have died because of the mass effect of that, but he would come in and they would shave away. They'd go up through his nose and they'd shave away at that tumor and buy him a few more months or years. One time he came in and he got a ileus from it, and they had to take him back in to do the to take out part of his colon because he had this ileus. And during that time frame, something happened that increased the proliferation of that brain tumor, and he ended up dying that hospitalization from the brain tumor. But you can also have palliative procedures like a paracentesis or a thoracentesis. One of the problems that comes along with advanced cancer is the protein malnutrition. Well, ascites is a problem that comes along with protein malnutrition, so they can get this huge belly that causes a lot of discomfort, not just for breathing and walking around with all this water on, but it impairs circulation coming back up from the legs and stuff, so they can get edema in the legs. And so they'll come in and have a palliative paracentesis. Is it going to heal anything? Is it going to cure anything? No, but it makes them feel better. And they can also do that in the lungs where they take fluid out of the lungs. Radiation therapy. The goal of radiation therapy is cure, control, or palliative. You can have radiation therapy to decrease the size of the tumor so chemo is more effective, or to decrease the size of the tumor because the patient will feel better. Again, if that happens in the brain, or if it happens in the abdomen or something, or if it's a tumor that's pushing on the heart. And there's different ways to administer it. The external beam radiation is one that we think of, I think, most frequently, where they're laying in a machine and they get a narrow beam of radiation. Okay. Brachytherapy is where that's is in the body, or systemic radiation therapy. They actually have pills they can take, or they can do it with IV radioisotope. Radiation therapy kills cancer cells by altering their DNA. Radiation therapy will kill healthy cells the same way. That's where we get a lot of the problems associated with it. Now, this is external beam radiation, and this thing that this woman's got on her head, that is to hold her head still because they want to use the narrowest beam possible, and they don't want to affect healthy tissue if possible. Okay? So they actually have these molds that they'll make with markings on them to where they can use that narrow beam radiation, but they can have body molds, limb molds, all kinds of molds to use for this. And then there on the far left is a tattoo, where they'll tattoo the skin to mark the area where they want to be irradiated. And that tattooing and stuff, that is done by mapping. They're going to map the tumor using a CAT scan or an MRI, and so they can pinpoint where they want the beam to go. Brachytherapy. This is a prostate brachytherapy. Over here on the far left is the size of the implants that they're actually putting into this fellow's prostate. Okay? And this is the position, the guy's in the lithotomy position, and this is his perineal area where that white thing is on there. This is a perineal area. And then he has a probe that's going into the rectum again. And this white thing has dots all in it. And the needles go into that dot. They go into those guides with the implants on them. And as they pull them out like this, they leave the seeds. Now, the good thing about brachytherapy is the patient can go home. The bad thing about brachytherapy is the patient can go home. It is recommended that a child not sit on a patient's lap who has brachytherapy for more than 5 minutes. And that somebody who has brachytherapy implants in should not be around pregnant women closer than 3 feet. Same thing goes with people who get systemic radiation therapy. There's radiation safety issues, and that's guided by, you want to limit time, distance, meaning that you don't want to be real close to them, that you want to stay as far away from them as possible. Okay? If you're really close to somebody who's having radiation therapy, then you want to limit your time. And you also want to wear shields, the lead shields, if you're dealing with somebody who's having radiation therapy. They're infused with radiation. They have radiation in them. They're radioactive. All right, and then I put a whole bunch of radiation therapy stuff up there. The patients are radioactive for like 48 hours after a procedure. So you need to make sure that you leave all the trash and everything in the patient's room. You shouldn't be taking the meal trays out. They usually use like styrofoam trays and disposable food eating products. You need to wear gloves if you're going to touch the patient. And everything, again, needs to be put in there in the room. Wash the hands with soap and water, not with the foam. Wash the hands with soap and water and rinse. Really good. Patients should be in a private room with a private bathroom, and men should be told to sit down to pee so they don't aerosolize the radiation. Rotate the patient assignment. Make sure that you have proper signage. And if the patient codes or something like that, you should take care of the patient. Because probably a one-time exposure to a patient who's getting radiation therapy is not going to harm you unless you're pregnant. And then after discharge, the radiation control officer needs to come up and test the room. Side effects of radiation therapy, remember there's no discrimination between cancerous cells and healthy cells. So they're going to kill healthy cells too. Local reactions include hair loss, I'm having such a hard time today. Erythema and desquamation, that means where the skin comes off, the top layers of the skin come off. That's not the same thing as exfoliation. This is where like sheets of skin come off. Stomatitis and xerostomia, anorexia, nausea, and vomiting, and of course we have the bone marrow suppression and pancytopenia. Systemic effects, fatigue, and malaise. And then late effects of this is it can cause scarring and fibrosis of the tissue that's been affected by it. If I had a friend of mine who had non-Hodgkin's lymphoma, and she actually had a large tumor in her mediastinum, and they did radiation therapy on it, and it scarred her pulmonary vasculature, pulmonary tissue, and it resulted in her having pulmonary hypertension later in life, and she ended up dying like by the time she was 42 because of that scarring. Now, the radiation therapy, she had that when she was 20. So that late effects from the fibrosis and the scarring can be quite devastating. Patient education, skin care, because it damages the skin. And they shouldn't use lotions. They shouldn't use deodorants on areas. They shouldn't use harsh soaps. They shouldn't try to exfoliate the area. They should really use a very gentle, non-alkaline soap product and not even rub hard on areas. Okay? Again, problems with loss of appetite and anorexia, so you have problems with nutrition. There's swallowing problems from the burns and from the desquamation. And taste changes. Food tastes weird. All right, then chemotherapy, same problem. Same problem with chemotherapy. They disrupt normal cellular function and proliferation. So the problems that arise occur because it also kills healthy cells. And again, you have this cure, control, and palliative goals for treatment. Now, chemotherapy won't kill all the cells, all the cancer cells, but hopefully it will kill enough that the immune system can kill the rest of it and keep it under control.
Is chemo the one that it said it only kills cells that are constantly replicating?
No. It tends to kill cells while they're replicating, but it kills cells, it can kill cells during, there's different chemotherapeutic agents. We're going to talk about that. There are cells that, chemotherapeutic agents that kill cells during the S phase or N phase are best for rapidly replicating, but you also want to use non-phase specific, non-cell phase specific chemotherapeutic agents too to help kill as many cells as possible. Why during replications? They're more susceptible to chemo during replication. We have the types of chemotherapy that try for to kill cells during the S phase. They disrupt the S phase, and then other ones that disrupt the M phase. And I'll tell you what, right now, that's all I expect you to know about them. A classification of drugs that there's several classifications of drugs that affect the S phase. There's a couple of classifications that affect the M phase, and then there's classifications that are non-phase specific. That's one thing I do expect you to know about the different types of different classes of chemotherapeutic agents. Like if I have a question, I might say, your patient's getting nitrous-urea that is a alkylating agent. So I'm going to identify it very well, and you would need to recognize that that's an agent that affects the S phase. Okay, I'm not going to ask you to list off every drug that affects the S phase. I'm going to give you a classification of the drug. Okay, so in order to kill as many cells as possible, you need to have cycles of chemotherapy so that you start getting cells that maybe aren't in the S phase later on. And that's another reason why you give the drugs that are non-phase specific so that you can actually affect the cells that aren't replicating at the time you're giving them the chemotherapy. Okay? All right, so we've already talked about this. We have the cell cycle specific and the non-specific ones. The non-specific some have a longer term action than the cell phase specific ones. So you can classify them by if they're cell cycle specific or non-cell cycle specific. You can also classify them by chemical makeup. So chemical group, we have alkylating, antimetabolites, anti-tumor, antimitotics, the topos, and then the others. And the others we're going to talk that you need to know are like specifically tamoxifen, because that's given frequently. All right, common adverse effects of chemotherapies. This is what you need to know, and then you need to know what to do for your patients who are having these common adverse effects. Again, I am not that worried that you know which one of those drugs causes heart failure. What I want you to know is how to care for a patient who has cancer and who's getting chemotherapy to help deal with these problems associated with it and chemo safety so that you can educate your patients about it. Okay, so I've divided them up into myelosuppression, GI problems, and then other effects so that it's easy for you to think about. So, of course, you have the problems with oxygenation and tissue hypoxia, tissue perfusion. You have problems with risk for infection, and then problems related to bleeding. Okay? Then you have the whole GI stuff that goes along with nutrition and elimination. And then the other effects are a lot of constitutional ones like fatigue and malaise. And then, shockingly, chemotherapeutic agents have a high risk profile for allergic or anaphylactic reactions. So that's something that you need to monitor for. Okay? And then organ toxicity, of course. Organs that are especially susceptible to toxicity include hearing, renal, liver, and then the heart. I don't think I have that many slides left. We're going to get through this, and y'all can take a break, and then Ms. Esky will start. People talk about the nadir of chemotherapy all the time, and all that means is this is when you have the lowest cell counts, your bone marrow is suppressed the most. I'm having class. Y'all need to keep it down. Each agent has an identified nadir, and people who are getting induction chemotherapy, we need to monitor that and keep an eye on them so when they're at the lowest point of their cell counts, we're doing all we can to protect them. So that is something that if you were an oncology nurse, you would need to know, and it is something to ask you about a lot of times on the NCLEX. What's a nadir? It's just the lowest point is when people feel the worst when they're getting chemotherapy is. Did y'all have something to add? When it's the lowest point, and it's when people are most susceptible to these problems of infection and bleeding. Okay? Vesicant injuries. Vesicant injuries are a big deal. This is somebody who's getting a vesicant chemotherapeutic agent through a port. Oh, but we're using a central line. We're using an implanted port. We're using a Grosjean. That shouldn't happen. It happens. Either because people haven't accessed the port correctly, the port's leaking, there's a disconnect between the actual port and the line. There's all kinds of ways that you can have central line vesicant injuries. Of course, we see them more frequently with IV, peripheral IVs, but this happens. Okay? Distal to that site, she may lose an arm. Areas that are distal to the site of the vesicant injury or the leak, they can lose it. They can lose that whole limb. Okay? So the mnemonic for what you do if somebody has a vesicant, what are the signs and symptoms of a vesicant injury? Intense burning and discomfort and redness around the site. Increased burning and irritation and redness around the site. Sometimes they'll get like instant blisters and stuff. Okay, so in order to treat this, you need to stop the infusion and try to aspirate. Do not remove, if it's a peripheral catheter, do not remove it. You talk to your MD, your unit educator, and the pharmacy and review the policy of what you were supposed to do for a vesicant for that type of drug, because each type of drug has a different procedure to try to mediate the effects. Okay? So you want to order the antidote and administer it. And when you administer it into the line, and then around the site, kind of like when people give local anesthetics, and they stick the needle in lots of places and infuse it there. It's the same way with the antidote. And then you put ice or heat, depending on the substance, on the site, and you do not elevate it. What does elevating it do? It increases return to the body. Okay? That's what you do for vesicant. Do I care if you know what you do for vincristine versus mustard gases, mustards? No, I don't care. I want you to know what the general treatment is. Hormonal agents like glucocorticoids, they can suppress cell division, and they're also used as adjuncts. Adjuncts are something that's used to mediate the effect or to help increase the effectiveness. So, glucocorticoids can decrease nausea, weight loss, and inflammation. You think about glucocorticoids can increase the mental state too, right? Because they kind of make you euphoric. If you stay on them long enough, they make you euphoric. And then we have hormone agonists and antagonists. These are used to treat cancers, germ cell cancers, that or cancers that need a specific hormone for growth. So men who have testicular cancer, you can give them estrogen because it will help decrease the growth. But what kind of side effects is that man going to have? Gynecomastia. Their hair patterns are going to change. They're going to have some atrophy of those male attributes. And then androgenics, which are male hormones, you can use those for estrogen-dependent cancers, but then, women start growing facial hair, and their pattern of hair changes, and the voice gets deep. I don't know if the voice gets deep. It might get deep. I don't know. But you need to educate the patient that they might have some of these specific side effects, okay? And then you can also have these biologic response modifiers, and these are supposed to help bump up the immune system, because we have things in our body that actually will attack cancer cells because they recognize them as not self. But if their immune system's been blunted, then they can have these biologic response modifiers that increase the responsiveness of the immune system and make it so they can fight the cancers more or better. Okay, and examples are interferon, interleukin-2, and monoclonal antibodies. And here's the thing, is if you think that you're only going to give chemotherapeutic agents if you work oncology, lots of us give interferon, and lots of us give gamma globulins and stuff like that, and those can be considered chemotherapeutic agents. There's a lot of chemotherapeutic agents in use for people who have autoimmune disorders. So you need to be aware of what you need to do for chemo safety, not just for yourself, but for your patient. Meds that affect bone marrow, because we know cancer and chemotherapy and radiation therapy cause bone marrow suppression. We have medications that we can give to increase production of platelets, red blood cells, and white blood cells. You need to know that. That's what they do. Combining therapies, combining radiation, chemo, and biologic modifiers allows for smaller doses of the toxic drugs and the toxic radiation. And it decreases the incidence of side effects or the severity of the side effects, and it's much more successful in treating cancers and sending somebody into remission or curing them. Other medications we use include antiemetics like Zofran, opioids for pain, and then anxiolytics like Ativan and Valium and stuff like that. Stuff that antidepressants are big in cancer treatment. All right, chemo safety, PPE. They want you to use latex gloves are preferred. They're thicker than the nitrile. And they want you to double glove. You double glove, you put one pair of gloves on, you put that gown on that's not very permeable to liquids, and then you put your other pair of gloves on over the cuff. And those are non-porous or low permeable gowns, and they want your gloves to come up higher than the regular gloves. Eye and face protection to prevent splashes, and then there's actual spill kits. Okay, yeah. No, they prefer them. That's why it says prefer them. They prefer latex gloves, but if your patient's allergic or you're allergic to latex, we don't want you to die giving chemotherapy because you're protecting yourself, okay? All right. Waste disposal, everything needs to stay in the room. How long do you think a patient how long do you think these chemotherapeutic agents stay in the body until they're eliminated, excreted? What? 7 days. Some of them stay in the body until 7 days. For 7 days. So while that patient's in the hospital Everything needs to be put in specially marked biohazard bags, including the linen. Waste disposal of stuff that had the medications in it, they have to go in special containers that indicate that they have chemotherapy agents in them. Because it can really cause damage to somebody who touches them or who's exposed to them. All right, that's it. You guys got any questions for me?